Uh, 51-year-old, it's not a high velocity injury, it's just he was parking his bike just fell off and he got this kind of fracture. He's a medical practitioner from a rural area, and this is the 3D CT, and you can see it's again a 4-part bad. There's a proximal fragment that's very narrow. We've got some more imaging here, and the head fragment is very small. Width is not much, it's about 15 mm. So the conventional wisdom would have been plating, and I'm very unhappy with that for this patient. So, and he's 51 and he's a medic, and I'm traveling the next day for my scuba trip. Didn't want to spoil my trip, so I said, go somewhere else, I will set you up. And he was hell-bent. He says, I'm going to rush in tonight. He got admitted at midnight. I saw him the day of the surgery. I was to operate him and leave the same day evening, and he insisted, so we had to do this. So now, how do you deal with this?
Can you go back to the X-ray?
ARS, yeah. For non-unions, I have. So I was not on that. That was not my this thing. So I just went in, and we told him that we're considering either a hemiarthroplasty or this device. So this is the Just Unique. And I thought, because he's 51, we ought to avoid. And I had this on my back table with the clear plan that this is what I would do. And this works well. I think the X-ray looked good and he was fine, and we've got a lot of images from surgery. But this is something that I like to do, where you've done the surgery and then you have to see the stability, and the GT assessment in one plane is not enough. It has to be a 3D assessment. So you not only do AP and axial, but you put it through all the circular motion, because sometimes you find that it's not centered or the GT is not sitting, and so it's been plastered and you can see the continuity there. So fairly content, and came back very happy, and I said, this is good and this is going to work, and explained, and he was happy and he went off, and we start mobilization reasonably well. I saw him only after 8 weeks because there were a couple of other trips, and then I was back and he was busy, and he should have seen me at 6 weeks, but again I was not available, so he came in. What happened in those 8 weeks, I don't know, but we didn't immobilize him. We told him that don't drive and go to your clinic. The understanding from the wife was that he started driving within 3 to 4 weeks, but he denies it vehemently, so I can't say what he did. But he came in at 8 weeks, and this was my assessment. He had about 90, 70, 40, 0, which was par for the course. I wouldn't have expected anything different, and his empty can was 4. So as I said, when the cuff strength is looking okay, then I know that everything is falling in place and he's doing well, and he'd come for rehab, and that's about the time we would start his rehab. So he was going to start his exercises. And then we did this X-ray, and I freaked out. I said, normally I should have done an X-ray at 6 weeks. We have delayed that to 8 weeks, and that doesn't look good, because that was not how it was. It should, as Shelley said, intramedullary implant, whatever you've done on day 1 should remain at 6-8 weeks. It shouldn't budge, because this is a central implant. Very highly compatible with good early mobilization. And that's the key thing. In proximal humerus, whether you do a plate or nail or whatever, if you start early, they achieve a good movement. If you keep them immobilized, then you've curtailed their function at some point. So I didn't like this. And then somewhere he said that he had 3 weeks later, he had sent me a WhatsApp message that he was hearing some crepitus in his shoulder. And that kind of was very unnerving. And when he came back, I said, what about the crepitus thing? He said, no, whenever I do the accelerator, I said, what accelerator? You're not allowed to do the accelerator. No, I was just starting the bike. I was not driving the bike. So crepitus. So I realized this fellow has been a pretty mess up, and this doesn't look good. And it's 8 weeks now. By 8 weeks, it should have gummed up nicely. So I said, we need to do something now. This is not going well. So what should we consider now? He's okay, his function looks okay, but that X-ray is not okay. And when the GT falls off, it is all or none. Trust me, if the GT unites, then it doesn't matter. But if the GT falls off, and that looked very scary, because, and the GT, I mean, sometimes you do the best result and the GT just undergoes osteolysis of a variable degree. So how many would add a bone grafting at this stage? Consent him for open reduction hemiarthroplasty, consent him for open reduction reverse, or you could still wait and watch for another.
So Ashish, why did you prefer for this implant?
It's my go-to implant. When I don't want to do a hemi and plating is not possible, that's the ideal indication. So I won't use it for everybody.
So here in this case, at 51 years, you are not thinking of replacement option if it fails.
So this is a modular implant. If it fails, you can take the top off, do a hemi.
No, but like he's 51.
Yeah.
My choice will be that if my fixation fails, I'll go for refixation at the age of 51. I won't go for replacement. Now that option is not there in this implant.
So because the head fragment was so small, it was not going to come through. See, when I do so an average medial lateral length is 50 mm. And I keep my screws 10 mm short. So I need a 40 screw, which means that the head should be at least 25 mm for it to hold, so that I can put in a 15 mm inside the head and 25 in the shaft screw. When I have a 18 mm head and I'm going to put 10 mm short because I don't want to go long, 8 mm is not going to hold as such. We have a fair series on these. So far we've been knocked out. I've had one failure on this patient, and it's for that middle age group where the bone cord is suspect. See, it's not a high velocity trauma. There is something going on there, which is like he just fell parking his bike in his house. So that was suspicious.
It's a nice concept. Only thing is that if it fails, then refixation is not an option.
Hemiarthroplasty is an option.
Yeah.
Which, if a plate had failed, my problem is the GT. But at 8 weeks, I think I can pull it in and still do a hemi without having to change the stem. The stem is modular.
Okay.
You have done plating. Would you have done plating if...
See, for these complex fractures, the plating doesn't give a good result.
Because why I'm saying is that your GT handling would have saved this. Because the way
No, the GT has been handled. I have done exactly for the GT LT what I would do for a plate. And these are transverse to whatever you do, hemi, plating, just unique. Your GT and LT has to be robust. Robust in the sense, we do the circle arch Frankels, I do the knee knot. I showed you on the video. That video has to be convincing. If it's not convincing intra-op, I take it apart there and change everything. So,
can we have the result?
So compared to plating, the just unique is a far better implant because it is central. You're preserving the head, so it's a win-win. You have not replaced the head.
So the results of...
We're very equivocal, I mean, it's almost equally spread out.
Yeah, I would think so, because even I am not sure. So I'm also exactly with you, I'm dividing.
Yeah, so let's move forward.
So I took him for consent. I said, I'm revising you, and we're going to do maybe a hemi, maybe a reverse, because that's the next stage. I don't think we can wait, and it's risky. 8 weeks is a long time. If everything falls apart, then it's a disaster. So whatever I need to do, it was very bold because he was devastated. He went off. He said, let me think on this. And he didn't come the whole day. And I thought he'd gone for second opinion and my problem was solved. He came back the next morning, okay, I'm resolved. You're going to do it. Whatever you do, get admitted. So I took him in and said, let's have a look. It's all there, exactly as it was. It's all there, exactly as it was, rock solid. I'm putting it through all kinds of motions and absolutely.
What was that last X-ray which you had shown us?
It was, I don't know, I can't explain, I've never seen it. I was so upset and I had just come back from a holiday and Monday morning is my worst day in my entire week. And he gets this X-ray and he shows, and the X-ray was done in our unit. And so so the crepitus, he was probably driving his bike and using it. The crepitus was there at 3rd week. That was when he had sent a WhatsApp message. See, when I tested him, he was good. If it was a non-union, he would not have active 90 degrees. He wouldn't have an active range of, when you get an active external rotation and your infra is recruiting. So the supra infra were grade 4 on my testing. So that should itself have told me wait and watch. But already I was guilty that I had done the operation and gone away abroad, no follow-up, direct 8 weeks, and then all this. And then the crepitus thing had played on my mind. Wife had poked in that, साहब उनको देखो ये गाड़ी वाड़ी चलाते हैं, हाइक तो उसने जोर से चिल्ला दिया, वो रूरल का है, वो बंद हो गया औरत. पर this is very unusual. I had never expected. I was so stressed out that my first surgery was failed. So that itself created a lot of baggage. Second, I said, revising this is going to be a nightmare. I'm just going to have to do a hemi for a 51-year-old medical practitioner. And he had reposed so much faith that he was ready to do surgery even if I was not there. Although I told him not to do there. But this is. So anyway, he is now about 3 months. This is at 3 months. He has improving. He's at home. He's just done 4 days of rehab with us and then at home. He is happy. He's pain-free. But if you get active external rotation, trust me that GT is in position, it's doing its job. Anything that's going to lag or zero, it means it's gone off as such. And that's all improving. Is gone to 120, 120, active is 110, active 30 is good. Is good. It's a very learning experience for me. But knowing the legacy that GTs fail, proximal humerus results are poor, I always had in the back of mind that this is not. Actually, the day one X-ray was amazing. The day one video was perfect. The suturing I know is robust. I've done it, and I know with that confidence I went. When I left for Thailand, I was like, I have done a fantastic job. I should keep a record of this case because this is going to do well. But that X-ray just gutted me out. So it was just one of those things. It just showed some part of the GT might have gone osteolysis, but it's all there. Everything is perfect. He's absolutely happy, thrilled. And anyway, so very little on the literature on this. It's a Babhulkar device gone into Just Unique. They've had about 4% or 5% failures. A lot of avians still preserved. 1 GT non-union. Only 2 of his 26 had to be revised, so 8% failure rate. There's only one study, Levon Dorsonian, the designer of this process, did Babhulkar and plating randomized in Paris. And they had more complications in the plating group, almost 37% complications and then 4 removal of implants. Here they had 2 avians.
Have you ever revised your own?
I have revised one of this. Again, another nice patient, he was 50, 55, and the GT fell down. It just didn't pick up. And after that, he spent almost 3-4 months, and he was due to go to USA. He postponed. So I changed that into a reverse, and he's doing very well. But he was a shattered case completely, so probably not a good choice. But we have a fair series. It's a quick surgery. It's a 20-25 minute surgery in the deltoid split. And you're not handling the head. There's the staple that goes in. If you place the staple in the center of the head, if you don't place it at the center, then it doesn't work. And you have a device on this where you can clamp the device in 3 stages and it reduces your varus valgus nicely. But the key thing is not the surgery. The passing the implant, putting the staple is very easy. Is the repair of the tuberosities. That's critical. But a lot of learning here for me, actually. So
Ashish,
no take home. It's just
Ashish,
power of miracles.
there is a question now. The study which you just mentioned here, have they mentioned the size of the head? And what is the minimum size of the head required for the staples to go in?
For this,
Yeah.
the strict contraindication is no fracture dislocations, no split heads.
No, the
And
size
this-
of the head. Like you said that
doesn't matter.
18 mm, you can't put the screw, right? For this,
For the plating. For this, they have 3 sizes of staples. The smallest staple is so small that it will take up any head. So there's no restriction on that.
but if the staples has not gone sufficiently deep, then it will come off.
No, it doesn't have to go deep. They have spikes on them. You don't have to go deep. You don't want to crush that head. It just have to be banged 3 times. That's it. It just catches it. The critical thing is the staple has to be a center. Bang in the center of that sphere, number 1. Number 2, their shaft implant was not of an extra small size previously. So the younger ladies couldn't receive abroad because for that plate to slide, there's a sleeve on top of that shaft. So now they have an extra small, which adheres to a 7 mm stem size.
Okay. Thank you, Ashish.
Thank you.
Thank you, sir. It was surely a very, very interesting case. Thank you very much.